So it's a complex biophysical process how an N95 works. And, they were originally designed for heavy industry, for people who paint cars or do masonry work or work with sandblasting and various industries. But there's no question that the N95s are much more effective. They're literally 95% effective at preventing the transmission of the virus from the person wearing the mask outwards and from the person receiving the virus inward. Breathing is an aerosol generating procedure. Talking, I don't think you have to be necessarily intubating. There's been studies that show that intubation actually generates less aerosols than just talking.
Welcome to the show, Dr. Zoutman. Thank you so much for coming on. Do
Oh, it's a pleasure to be with you here today, Ron.
you mind giving a brief background of yourself and all your expertise?
Oh, well, I'm retired now, a physician. I've been in the medical field for almost 45 years. I practiced as a specialist in infectious diseases and medical microbiology and worked at Queen's University as a professor, teaching medical students and nursing students and all kinds of people. Uh, Involved heavily in quality improvement program, graduate program at Queen's University. And we run the longest standing online infection control course for health professionals, um, now into its 20th year, which is and over 4,500 students have graduated. So it's quite something. I been involved in hospital administration as well. I was chief of staff at Quinty Healthcare and the inaugural chief of staff at the newly formed Scarborough Health Network in Toronto. And currently, I guess, semi-retired. I don't do clinical practice anymore, but I still teaching and doing some research and significant amount of advocacy on infection prevention and control that still seems to be necessary.
You have a wealth of expertise, and I remember reading your bio when we did the process improvement course and just reading about everything you've done. I felt like such an underachiever, and I commend you for all the work you're doing, especially in the field of health quality and infectious disease. I can assure you you're making waves on everything you have done and continue to do.
Oh, thanks very much. It's good to know you're having an impact. Some days it doesn't always feel like that, to be honest.
How come? Why does it feel like that?
Oh, well, I mean, we're in a situation with COVID in particular where I think we've seen a real tragic failure to adopt, the attitude that we should try to control COVID and where we'll never eradicate it. Eradication is like we did with smallpox in 1977. We got rid of it. It's gone. It's in some freezers in some laboratories, but never to be seen again, hopefully. With COVID, that seems unlikely, but we can certainly control COVID. And what we say, instead of eliminating it, eradicating it. Eradication means, as I say, completely getting it down to nothing, but eliminating means COVID is down to a controllable nuisance level where, it doesn't cause that much destruction and misery. I was just looking on the Health Canada site, which isn't very accurate, but they're talking about over 2,000 cases of COVID-related deaths in mostly 65-year-old people and older across Canada in the last 8 months or so, since August. I mean, stop and think about that. That's 2,000 mortality. Normally, that would cause a big ruckus, and that would get people very excited, and no one seems to notice.
So that's unique about smallpox that we could eradicate it through the vaccine, but correct me if I'm wrong. Is that because smallpox, the only vector to that disease was humans, so that's why we could eradicate it?
Yeah, and the vaccine was widely applied, and it's a horrible disease and very frightening because of the pox that occur over people and so forth. And it's been around for centuries, unlike COVID, which has only been around for 5 years. And it was a very concerted effort, and the vaccine was effective. And so, the World Health Organization said we had eradicated uh, smallpox, whereas elimination means just getting it down to, a very low level so that it's not causing, massive outbreaks all the time.
And COVID-19 is particularly unique, same with RSV and influenza, that they have short incubation periods and they're highly transmissible. So, how does that make it difficult to eradicate or keep at bay?
Yeah, I mean, it's a real challenge. I mean, if I had to, compose an exam question for students, please describe for me the characteristics of a virus that would be really hard to deal with. They would be describing, effectively COVID. It's airborne, so it's spread in the air, and it can, although a lot of contact between people is very close within a couple of meters, particularly for paramedics, you're up close and personal with people. So we'll talk more about this later, but there's the droplets in the aeros and then the very small aerosols. But then the small aerosols linger around and hang around and float around in the air for several hours, even after someone has left the room or in your ambulance rig or whatever. And so we know that we can prevent the spread of this with the current technologies.
So that's such a good point because if it's airborne, then we need an N95, especially as healthcare providers, paramedics, and everything. Why is an N95 optimal for an airborne disease versus a surgical mask?
Yeah, I mean it relates to the structure of the product. N95s are built in a particular way. It's called blown polypropylene. It's fibers of polypropylene in random distribution to form a netting. It does not work like a sieve. It's not like the sieve you use, when you're making macaroni to get the water up. It has electrostatic properties. So the viruses and the droplets and aerosols are electrically attracted to the fibers. They also smash into the fibers and get entangled. So it's a complex biophysical process how an N95 works. And, they were originally designed for heavy industry, for people who paint cars or do masonry work or work with sandblasting and, in various industries. And then we realized it would be a good idea for things like tuberculosis and measles that we long agreed are airborne. And then there's been this endless raging debate. Oh, are they effective for the so-called common respiratory infections? That debate was percolating along, and then it hit a feverish pitch when we got into COVID. Because, what do you do? Well, problem was, think back to 2020 when COVID hit, we didn't have a stockpile of N95 respirators anyway. So the argument was rather moot until the latter part of 2020 when the production locally in Canada revved up. But there's no question that the N95s are much more effective. They're literally 95% effective at preventing the transmission of the virus from the person wearing the mask outwards and from the person receiving the virus inward. And so if two people, person who is sick, say your patient, and you as the paramedic are both wearing N95 respirators, the chances of transmission become, phenomenally reduced. Not zero, but, really tremendously reduced. And so I think one of the difficulty and the argument that rages is that, have we been able to do a randomized control trial to demonstrate that, N95s are going to be more protective for all the paramedics in Canada or all the nurses and doctors in Canada working in hospitals and clinics? Unfortunately, we don't have that randomized trial that's really properly randomized and properly controlled. There's lots of other studies that have shown N95s being used to prevent the spread of COVID. My favorite example is from a bone marrow transplant unit in Germany, where you have the most high-risk patients you're ever going to see who have no functioning immune system after a bone marrow transplant. And they do get a lot of infections, including viral respiratory infections. And in this unit, they had the nurses and doctors wearing N95 respirators continuously while they were working. And they had the patients wearing N95 anytime they came out of their room or if people came to visit in their room. Otherwise, they were by themselves in their room. They didn't have to wear it. and they had good data about their respiratory infections, flu, RSV, and COVID in that group. And they continued to watch them, and they knew that patients did get respiratory infections before this intervention. And after this intervention, they reduced those infections by over 90%. It's not a randomized trial, but it's a very tightly controlled study. And there's many more examples like that. And as we're going to talk about later, Ryan, there are other things to do other than N95s. It isn't all just about N95s. There's lots of engineered solutions that are very, very effective. And I'd like to talk to you about with respect to paramedics as well.
Yeah, please do, because all I'm thinking is we tend to always gravitate between binary solutions. It's like mass work or mass don't work, when it's like the James Reason's Swiss cheese model. I need to do multiple different things to ensure we have an overall effective solutions. And of course, nothing is going to be 100%. There's always holes in the Swiss cheese, but we need as much solutions as possible to mitigate any holes from occurring, especially for the most vulnerable people, because you think cancer patients, HIV patients, or just even the elderly, 65 years and older, they're disproportionately affected. So, what other measures do you think paramedics or other healthcare providers can do to ensure their safety and the safety of the patients?
Well, I think I would certainly encourage all paramedics to advocate, and the different ways to do that, through your organizations, through your unions and occupational health and safety. I think you need to really put a strong emphasis on that. Again, that will talk about protecting paramedics, which is important, but also protecting vulnerable patients who, if you get COVID, they get into more really serious difficulties. The technologies I could talk about for a long time because there's a lot of really cool, fun stuff, and I love technology. So it's not we've talked about N95 respirators. Certainly, surgical procedure masks do provide protection, maybe in the 30% range. The KN95, the one with the ear loops that sometimes don't fit that tightly, you're getting into the 50, 60%. And then there's the N95s. And there's been a new product I want to mention in Canada, put out by Canada Mask. That's spelled MASQ. I have no relationship with this company other than buying their product. But they've come out with a mask known as the Q100. And it looks like a KN95. It's like the ear loops, not the head straps. But they made them so that they're very breathable. And that means that they're less fatiguing and you barely even know you have them on. And they are certified as a N95 by Health Canada. And they brought to my attention maybe 8, 9 months ago. So I bought a case, tried to like them. They fit me really well. I got a smaller size for my wife. And they're excellent. And I actually went and had myself quantitatively fit tested. Well, okay, let's see if these are as good as advertised. Well, they passed for me the fit testing, which was impressive. And so I use them on a routine basis. Again, they're Canadian products, so I'm all for that. So there's new technologies in masks, and I think the Canada Mask Q100s are one example of a Canadian invention and a Canadian improvement, and we're going to see more. The other is in methods to clean the air. How do you clean the air in buildings? Let's start with that. Well, we've known that since we've gotten into sealing our buildings very tight. If you watch houses being constructed, they're racked up in the building wrap, and then there's layers upon layers. Not a lot of air is going to leak out. The windows are now very tight. And we did that to save energy, but the consequence was no air movement. So houses got kind of stuffy, carbon dioxide levels went up. And so things that we can do in certainly public buildings, which are modern buildings are built the same. Old public buildings like a lot of the lecture halls at Queen's University were built in the 1800s and early 1900s. They're pretty drafty. Maybe there's a benefit to that in some ways. But the buildings now are pretty tight. And so we have to rely on the ventilation system. And so there's been a substantial debate, and the American Society for Heating and Refrigeration, known as ASHRAE, um, is an American standard, but it's used internationally and relied upon in Canada. Has a new standard came out in 2023 called ASHRAE 241. And that standard is, pretty technical. So it's logical to ask if you're, in a paramedic station or in a bank or in a hotel or in school or university, what are the air changes per hour? There's different ways of expressing it. Obviously, it relates to the number of people in a room. So air changes is one thing because fresh air in, bad air out keeps the CO2 levels down. That's a proxy for the measurement. If the CO2 goes over 1,000, you got a problem. CO2 is below 600, you're looking pretty good. The other is filtration. Can we filter these little rascals out of the air? Well, you can. We all know what HEPA filters, high efficiency particulate filters. And that's people can buy those even for their furnaces at home. And that improves things. And so that's the other step is filtration and then ventilation. And the last is disinfection of the air. And there some old technology going back to the 1950s and 1940, where experiments were done by Mildred Weeks Wells and William Firth Wells, two scientists in eastern U.S. years ago, who looked at the role of ultraviolet light in killing bugs in the air. They were really concerned about TB, which is still a major killer infectious disease today. They demonstrated that ultraviolet light at the right wavelength, 254 nanometers, kills viruses and bacteria. William Wells, they were a husband and wife couple. William Wells was interested in tuberculosis, and he showed that air pumped out of a tuberculosis ward, which was just teeming with tuberculous bacteria floating in the air, that was pumped out into a special room that contained hamsters. And the hamsters would get infected with TB or guinea pigs. I'm not sure what animal. I think he used guinea pigs, actually. That if he used UV lights in the ductwork or in the near the cages of the animals to kill the TB germs, they didn't get sick. So he demonstrated that ultraviolet light was very effective at killing TB germs, and his wife, Mildred, did the same for influenza and through other viruses. This is simple technology. I mean, we've had this technology for almost 80 years, and it can be installed. It has to be above your head. It has to be at least 8 feet. But a school or your ambulance bay, for example, will have very, very high ceilings. Well, the air that we breathe and the air around our bodies, we're basically heating elements. So there's a plume of warm air leaving our bodies going straight up to the ceiling because hot air rises. And then it floats around the ceiling, and then it cools down and it comes back down. And so if the ultraviolet light is up at that level in ceiling height, 8 feet and up, and it's shielded so it's not going to hit you in the eye and burn your skin or cause skin cancer, it's very effective. Anyway, so that's a fairly long-winded answer to some of the key elements in Riesling's layers of Swiss cheese: the ventilation, the filtration, the UV lights. If you combine all of those, you can get 95% or 98% reduction in coronaviruses, influenza viruses, RSV, and TB, which we just aren't doing, and we really should.
So what I hear you saying is we have a lot of factors we can control. And I know a lot of that is done in the in-hospital setting, but I can give you some anecdotes that happen quite commonly. Imagine it's flu, cold season for paramedics. We walk into a house, and it'll tie back to that. Houses don't have a lot of filtration and ventilation. And we walk in, you get blasted with cigarette smoke because it's so stuffy in there and you can taste it. And imagine this person has a pneumonia and they're coughing and the filtration, the ventilation's poor, then we move them into the back of the ambulance where it's this very concealed box and they're breathing out these infectious particles and the hot air rises, then cools down, comes back down, and now we're exposed. However, some ambulances do have HEPA filters or HEPA filters in the ambulance as well to mitigate the risk. So, is there anything else paramedics could do besides wearing an N95, putting on the filters, and having good ventilation to protect themselves and also the patient?
Yeah, paramedics are in a very unique situation. As you say, you walk into that apartment where there's no air changes, right? And as I said, houses, if you're lucky, you get one air change per hour, which is not clear enough. So yeah, the N95, not negotiable as far as I can tell. I mean, I guess we've also seen pictures of paramedics wearing PAPRs, and that's an awful lot of equipment, heavy. Those are getting better. That technology is improving. There's a one-piece helmet-like apparatus that's all contained in the helmet. There's no HEPA filter fan attached to your waist on a belt, but still a heavy, clunky thing to have on your head. So, yeah, I think there are things that you can do inside the house. Well, you're at the mercy of the environment you're in. So, wearing an N95, being fit tested is critical. And if there's the facial hair issue for guys, that's a problem, and that's going to reduce the effectiveness. Some people will not remove facial hair for personal or faith-based reasons. Totally respect that. That's where the PAPRs may become necessary. And if I was a paramedic, and I would say if you wear an N95 for the indoor calls. I mean, if it's out on the street, the risk is different, but there's still blood and fluid flying. So you may be wearing it, a waterproof one for a different reason. So the other things you do that I think are engineering solutions are what can you do in the ambulance, the rig, to improve the air handling. I mean, they're very sophisticated machines. You always got the engine running. So yes, the ventilation could be built in the rig to take the air that's in the rig and push it out and to bring new clean air in. Wouldn't even necessarily need a HEPA filter then, would you? Or if you're going to recirculator, then you need to pass it through a HEPA filter. HEPA filters have to be maintained and changed and whatever, but you can do that. My car has a HEPA filter for some reason that I've learned. So I guess I could drive my car through a biocontaminated zone or something. But you can do the same in your paramedic rig. And you may even want to have the driving compartment sealed off with its own ventilation separated so that you're not sharing the air. So that the back of the ambulance where you're tending to the patients. And you would need a significant, amount of air changes to allow for the volume of air. You got 2, maybe 3 people back there, very close quarters, lots of aerosols, we know breathing generates aerosols as much as anything else. And I want to say at this point, this whole notion of aerosol generating medical procedures is falling out of favor as a concept. Breathing is an aerosol generating procedure. Talking. So, I don't think you have to be necessarily intubating. There's been studies that show that intubation actually generates less aerosols than just talking. So those are some of the things. Ultraviolet lights could be turned on in the rig after you leave, or they could be built into the ductwork so that you won't see them. I don't know if that technology is available, but certainly it is possible. But in paramedic world, in your ambulances, there's a lot you can do to also UV lights have some effect on surface contamination as well. Less of an issue for COVID. Never been much of a surface virus that you pick up. There's an element of that. So hand hygiene still had always been a good idea, always will be a necessity. So there's lots of things that we can do and that we should do and needs to be advocated for in the design of new ambulance rigs.
I appreciate those system designs and changes because the ambulances do have good ventilation systems and the HEPA filters in some of them, but imagine the ultraviolet kind of implementation, like that'd be amazing. And you bridge to my next question about the aerosolizing generating procedures, because during the pandemic and just hearing infectious disease experts like yourself talk about how if we sing, I will generate aerosols that can float in the air. And the best analogy I heard was think about cigarette smoke. Like if you smoke inside, you're going to have all this air float around into the room. And of course, that's a lot different if you smoke outside. So that's why if we breathe it in, could become infected quite easily in a low filtration and low ventilation area.
Oh yeah, if someone had COVID and then left the room, and then you walk in a couple hours later and it has the typical, minimal ventilation, very much been shown to allow for the transmission of COVID. One of the best examples is the isolation hotels. Remember, for example, New Zealand was very strict and they were very successful. Getting into New Zealand was very difficult, and you had to go into prolonged quarantine in a hotel. And what they discovered is people were transmitting COVID between themselves. How is that possible? You were literally cooped up in a hotel room and you weren't out. But some people would go out into the hallway, and they were demonstrated because there was closed circuit TV watching them in the hallway. They'd go out in the hallway, hear them talk or whatever, maybe cough, and then someone else would come after them, however long after, and they would pick up COVID. And it was demonstrated, that was the only way that could have happened. It's been demonstrated multiple times. One of the other interesting examples in Ontario, a study done, I think, in an apartment building was demonstrating transmission of COVID through the interstitial spaces between the walls where the pipes and things run. And if you've ever looked under the sink in some buildings, particularly apartment buildings, where the pipes come in for the drain of the sink, there's a big hole there. It's not been covered up. So plumbers have access on the maintenance issues, but it allows air to transmit between suites very readily. And that's been demonstrated. So people are literally getting COVID lying in their own bed. There's an issue for building standards and ventilation. It's overwhelming the amount of information we have that COVID is airborne and is transmitted exactly like smoke.
And that makes me think of measles, and that's timely too, because that's the one of the most infectious disease known that we have, and how children with measles will go to the doctor's office, and even hours later, if the filtration and ventilation's suboptimal, people could still get infected because it's still lurking in the air.
Yeah. Well, measles is the best example. I mean, we consider it the most infectious of all the infectious diseases, with a reproductive number of 12 or higher, meaning that if I have measles and I'm in a room of people, I will, on average, infect 12 other people. That's pretty phenomenal. COVID is in the 6 to 8 range, depending on what's going on. And Omicron that hit us with a tsunami of Omicron in the late 2021 and early 2022 had a much higher reproductive number, in the range of 6, 7, 8 as well. But measles is pretty spectacular, and we're seeing the effects of that right now. It takes very little to transmit measles.
Why is that?
Well, why some organisms are transmitted as airborne and others are not is kind of a fascinating question that I don't know if we know the answer to. Remember, it's not just viruses. Tuberculosis has been known to be airborne thanks to the work of William Wells and his experiments, and showed that, it was airborne, and there were things we could do to prevent airborne transmission. They didn't have N95s back in his day that I know of. So tuberculosis is a very large bacteria that tends to clump together as a bacterial cell. I've worked in TB labs and I've handled the bacteria, and it amazes me that it's airborne, but there's no question that it is. And it's beginning to look like we have severely underestimated all the stuff that is airborne.
This channel and its content are created independently and not affiliated with or endorsed by any employer, agency, or organization. The information provided is for educational purposes only and should not be considered medical advice. Viewers must follow their local paramedic guidelines, clinical standards, and applicable laws when providing patient care. Always practice within your scope of practice and seek direction from authorized medical oversight when required.